So it's my pleasure to introduce Doug White. It's the latest Meneely George speakerships. To me, this is one of the most impressive lectureships I've ever seen. It's tangible evidence of Dr. George's work. If you look back over the list of people who have presented in this forum, it's pretty remarkable. If you know anything about sort of the pantheon of pulmonary and critical care medicine, the lecturers really all are members of that. People like Talmadge King, who's written prolifically on pulmonary fibrosis, Bob Bartlett, who is arguably the grandfather of ECMO, Ken Leeper, who is one of the PIOPED investigators, Wes Ely, who is from here and really helped spearhead changes in how we think about sedation in the ICU. Richard Light, who everybody knows, set up the Light criteria for judging of pleural effusions, and of course, Dr. George himself. Dr. White graduated from Dartmouth, Phi Beta Kappa, went on to UCSF, where he graduated AOA. He took a 9-month hiatus, is that right? 9-month hiatus from medical school to do silly little extravagant easy things like climb Mount Everest. He quickly points out that while he didn't actually make it to the top, he was not the weak link that caused their ascent to stop. He did his clinical training in internal medicine and pulmonary and critical care at UCSF, getting his master's along the way in epi and biostats, followed by a 2-year fellowship in clinical ethics. He was on the UCSF faculty until 2009 and was the director of the UCSF Clinical Ethics Core and Ethics Education, the director of the Ethics Education. He's now out at the University of Pittsburgh as the UPMC Chair for Ethics and Critical Care Medicine. Pittsburgh, for those of you who don't know, is well known for very aggressive critical care, and it's interesting that they brought in an ethicist to complement their work. Dr. White has done multiple invited lectureships and has numerous awards. He's well published in this domain. And I find it interesting, his grant support has really run across the spectrum at NIH, everything from NHLBI to the National Institute on Aging. He's currently, if you look at the E-Reporter, he has 3 active awards, all looking at communication in the ICU. And I really look forward to this because I think it's nice with Dr. Marion's interest in end-of-life issues, Terry Davis's and Connie Arnold's interest in communication and all, plus the expertise in critical care that's here. I think he's an outstanding speaker for this audience. And with that, Dr. Walker.
Thank you. I'm very honored to be here, and thanks, Bob, for such a warm reception, and for the dinner last night. I had a great time talking with Dr. George and Dr. Payne, Dr. Marion. It was really quite lovely. And then also I just had a great time getting to know the fellows and seeing the interventional pulmonology in action here. It's an impressive group. So today we're going to be talking about an issue that is near and dear to my heart, responding to requests for futile or potentially inappropriate treatment. And let me just get some research disclosures out of the way. This is where my research funding comes through, as well as consultancies for UpToDate, where I do write the chapter on this same topic. So if you want a summary of what I'll be talking about today, this mirrors what is in the chapter. Okay, so just to get sort of a pulse of the room, I want to start with a case, and as a show of hands, my question for you is treatment futile, according to whatever definition you hold in your head of futility, okay? So a 71-year-old man with moderate dementia and severe COPD is admitted with respiratory failure to your ICU. He has septic shock and multi-organ failure and does not have an advance directive. He's in the ICU for 6 weeks. His course is complicated by a number of things, but one of them is watershed infarcts that leave him in technically a minimally responsive state. He is 6 weeks in, ventilator and dialysis dependent, thought to be this will be indefinite given his baseline disease. But he's off vasopressors and has quote-unquote stable vital signs. He also, because of the heavy pressure requirements early in the stay, has progressive necrosis of his fingers, toes, nose, buttocks that have required serial debridements over time. to ward off wet and dry gangrene. And so you talk to the family, and essentially they insist on ongoing treatment and say that he believes that life is sacred. We think he would choose this life over death. Okay, so show of hands. How many people think this is futile treatment? Okay, how many people say, no, not futile? Okay, and how many people don't know because they don't know what the definition of futility is? That's a reasonable answer. And so over the course of today, of the next hour, I'd like to explore the nature of these disputes and suggest a new mental model for how we should be thinking about these cases that move away from the term futile treatment to another term that I'll talk about. And then present new professional society guidelines that were recently released about how to manage respond to and resolve intractable conflicts with surrogates about these kinds of cases. So just taking a step back, for those of us who practice in intensive care units, I think we all know well that this is an important issue, but there are other ways to look at this in terms of epidemiology. Both the frequency and cost of this in ICUs is relevant. This is an interesting study out of UCLA in which Dr. Hun, across UCLA's 5 ICUs, every day surveyed the intensivists and asked, are there any patients you're caring for whom you believe that treatment is futile? And did not define futility, just said according to whatever definition you hold. And what they found is over the course of the study period, 11% of the patients in their ICUs were receiving treatment perceived to be futile by the attending physician. They did a cost analysis of the care and found that it was about, in these patients, it was about $2.6 million over 3 months on the treatment days in which treatment was believed to be futile. And this is not just a North American issue. So this is a study published by Ruth Pierce and Ellie Azoulay in JAMA in 2011, in which they essentially looked at the same question, but they did the study a little differently. This was about 80 different ICUs across Europe, and on a single day, May 11th, 2010, I believe, they went and they asked about every patient in the unit at that point, is there any patient, or is this patient receiving treatment that you believe to be inappropriate? So they didn't use the term futile, they used the term inappropriate. And what they found is that in this many center study, 16% of clinicians judged that at least one patient under their care was receiving disproportionately aggressive treatment in light of the prognosis. So again, another way of looking at this and seeing this is quite a prevalent issue. And if you think about, well, what guidance exists for us now on how to respond to these issues, these are the 3 main societies that have put out professional society guidelines on how to respond, and it's worth just sort of establishing what's the baseline before the most recent policy was released. So let me just take you through this. There's the professional society, there's the definitions that they used, and then there's what approach to resolution is recommended. The American Thoracic Society defined a life-sustaining intervention to be futile if reasoning and experience indicate that the intervention would be highly unlikely to result in meaningful survival for the patient. And how to resolve these cases if the surrogate or family disagrees, no resolution given. The Society for Critical Care Medicine took...
Who decides meaningful survival?
Yeah, so these are the issues that we'll unpack over the hour. Right, lots of value-laden terms in here. Highly unlikely, meaningful survival, if reasoning and experience indicate. The SCCM, by contrast, tried to go a very different direction. Treatments should be defined as futile only when they will not accomplish their intended goal, i.e. treatments that have no beneficial physiological effect. So this is meant to take it into the realm of what's very objective, presumably, and what clinicians presumably can diagnose. And so how to resolve these disputes? Well, the SCCM was not clear on what to, they didn't say what should happen in the face of this, but in general said a procedural approach should be pursued that adheres to accepted conceptions of procedural fairness. And then finally, the American Medical Association took an entirely different tack from either the ATS or the SCCM and said, we can't define futility. We're not going to define it, and you should purely resort to a process of dispute resolution, and they outlined a 7-step process about how to proceed. So a lot of variability, even in the kind of guidance that clinicians would look to say, how should I respond here? How should I manage these cases? So let's for a moment, and I think this will address your issue, let's unpack what's really going on in quote-unquote futility disputes. So I think in my research and in practice, I think about mental models, which is a sort of a decision analytic frame to think about essentially the interpretations of the world that affect, or the lens that affects how we see the world and what happens. And I would offer that the model that many clinicians carry around for quote-unquote futility judgments is something like this. These are relatively straightforward, uncontroversial judgments. Therefore, I should be given discretion to make these decisions at the bedside. So this, I think, is a fairly common mental model. And let's look at some problems with that mental model. The first is the claim that these are straightforward technical judgments, when in fact, I think under scrutiny, it becomes clear that these cases actually really hinge on controversial value judgments. So what do I mean by that? Well, listen, in reality, it almost never happens that surrogates and ICUs request treatments that have no chance of accomplishing a physiological goal, right? That's just not what drives most of these cases. Most of these cases are about something different than that. You know, the patient can be physiologically sustained. The question is a moral one, a value-laden one. Is this right? Is this good for the patient? And so, in fact, if you look back and look at the case that I gave you to motivate this, in fact, right, the vital signs in this patient are stable. He's on a ventilator, he's on dialysis, his physiology can be maintained, his body can be kept alive. The question is something different. The question is, are there situations in which the patient's life could be extended, and doing so is requested by the patient or proxy, but doing so would be ethically wrong? And so, in fact, this is the second part of the Hun study was asking clinicians, well, why did you think the treatment was futile? And if the mental model that I'm proposing was really the one, if it was really all about these are just straightforward technical judgments, we would see that. But instead, what we saw is essentially clinicians were making value judgments about what's, and I should say at the outset, I don't say that in a pejorative way. I think value judgments are necessary. But they were making value judgments about burdens and benefits, about whether a life that can't be lived outside the ICU is a life worth living, and then whether a life of permanent unconsciousness is a life worth living. This is just a general way of saying these are value-laden judgments that we are being asked to be involved in as clinicians. And so when we think about this, there are a number of competing ethical considerations that come up and that make this an ethical dilemma. And I would just briefly outline them to be these. Patients have an interest in living according to their deeply held values and preferences, as do clinicians, both their own deeply held values and preferences, as well as acting in accord with their best conceptions of professional integrity. And then third, and I think this is probably derivative of what is the conception of professional integrity, society more broadly has an interest in the just allocation of scarce resources. The second problem with the mental model of, well, this is just a straightforward technical medical judgment is this, is that when you ask clinicians to make judgments about the same case, you get huge amounts of variability in what they think is appropriate. So some evidence of this, there have been a number of studies, but just to build on the same study we talked about by Pierce and Azoulay. So in all the cases in which at least one clinician in those ICUs said, yes, I think treatment is inappropriate, they looked to see among the multiple clinicians who were sampled for that patient to see whether there was consensus. Did everyone agree? And in fact, usually it was between 2 and 4 people who weighed in. And what they found is that in 85% of cases in which one clinician said, yes, I think this is inappropriate, there was disagreement within the clinical team. So one clinician said, I think it's appropriate, another said, I think it's inappropriate, et cetera, in 85% of the cases. I think just, if anything, it's driving home the reality that these are complex judgments that are not typically widely shared by clinicians.
May I interrupt you because I think these are critical points. More than one person on each of the teams said the treatment was inappropriate. That's not to say the treatment should not be done, or any treatment should not be done. Could mean the patient doesn't even need a urinary catheter, and if you keep it in, that's inappropriate. So what exactly are you saying here? Are they saying 85% of cases, there was agreement of the clinical team that nothing should be done to this patient?
That in these cases, that the treatment was that the invasive life support, which is what the study was focused on, was
You
viewed to be
should put that
inappropriate.
clearly in. This is how you get to
yeah.
conclusions
Let's-
where you lead people who are listening to conclusions that are not held up in science.
Well, let's get beyond this. This is just sort of summarizing the epidemiology of where the field is now. Okay, so let me give you an alternative mental model, which is that these are controversial, value-laden judgments that inevitably must be addressed, but we should proceed with great care when doing so. And so if that's the case, if we accept that these are hard value judgments, that indeed are not mere technical judgments, I would offer that the term futility is probably not a great label for these cases. And this is just a simple semantic issue, but I think for many clinicians, when we invoke the term futility, we're not just describing a situation, we are describing what should be the acts that should be taken beyond that. When we say futile, we are meaning we should stop doing anything that's meant to keep this patient alive and let them die. And so you don't have to look too far, actually, with what exists currently to see that this distinction is being made. So in 1997, the Society for Critical Care Medicine issued a consensus statement on futile and what a second term, potentially inadvisable treatment, where they defined futile interventions as interventions that will not achieve the intended outcome. And they went on to note that these are extremely rare circumstances, right? Very rare that patients or surrogates are asking for things that have no chance of benefit. And they went on, this was written at a time when cost control was very much on the radar of people and made clear that this will not be a significant tool for cost control. They went on to outline a second class of cases that is not a sort of a more objective judgment of efficacy, but is what they labeled potentially inadvisable treatment. And they described this as treatments with at least some chance of accomplishing the desired effect, but clinicians believe that competing ethical considerations justify refusal. And they outlined the sorts of things that might be relevant to these ethical debates. The treatment is highly unlikely to be successful, it's extremely expensive, or it's intended to achieve a goal of controversial value. They didn't do any saying of at what threshold would this be adequate, whether it's expensive or unlikely to be successful. They just named it, that this is a different class of cases than the strictly futile interventions. And so let me just introduce the beginnings of what I'll talk about for the rest of the talk, which is a recent professional society guideline that I co-chaired with Gabriel Boslett, who's at Indiana University, called an official policy statement responding to requests for potentially inappropriate treatment in intensive care units. I'll just tell you a little bit about the participating societies. There were 5 societies, the ATS, the Society for Critical Care Medicine, the American Academy of Critical Care Nurses, the ACCP, and then interestingly, the European Society of Intensive Care Medicine was also one of the core professional societies involved. And we had purposefully assembled a diverse group with both medical backgrounds and a number of different specialties, pediatrics, nursing, law, bioethics, and then we also had public and patient representatives. So what I'd like to do is just take you through some of the recommendations. And first on this issue of terminology, the first recommendation in this document that was, I'll work through this over the next 10 minutes. The term potentially inappropriate treatment should be used rather than futile to describe treatments that have at least some chance of accomplishing the effect sought by the patient, but clinicians believe that competing ethical considerations justify not providing them. So this is merely a sort of a terminology recommendation. It's not what we led with, but we thought it was an important distinction to make. We also went on, well, let me say a little bit about why we thought that was important. I think from what I've said, it should be clear, but the term potentially inappropriate was chosen consciously to nudge clinicians to think about these things in a different way than they typically do. So rather than to think this is futile, I should stop and I should have the authority to stop right now, the term potentially inappropriate is clearly preliminary, right? The word potential signals that these are judgments that are in fact preliminary rather than final and need some sort of verification before being acted on. And the term inappropriate was also chosen to explicitly make clear that these are value judgments. These are value-laden, difficult choices that we're talking about here. And we think the term inappropriate conveys that much more clearly than the word futile. So we also outlined a couple different categories. So this is, from a definitional standpoint, what I just said about potentially inappropriate treatment is listed here. Futile interventions were defined narrowly. So we did define futility. We said futile treatments are those that cannot accomplish the intended physiological goal. And this is a very narrow conception of what's futile, right? So this would be administering CPR in a patient with rigor mortis, administering antifungals in response to a request for this in a patient with an acute MI, right, who has no known medical indication to antifungals. So we went beyond the AMA's approach of saying futility cannot be defined. And instead we said, yes, it can. We're going to define it in a narrow way. And we're also going to create a second category that captures what are the more common and more value-laden judgments. And then there's a third category that I think in clinical practice we often ignore, but it's also worth noting that we often refuse to provide things not because we have a general moral intuition that it's wrong, but because our moral intuitions are supported by legal, either laws that are in place or some other socially sanctioned mechanism. So legally prescribed or discretionary treatments are those that may achieve the effect sought by the patient or surrogate, but for which there are laws, judicial precedent, or public policies that prohibit or permit limitation of their use. And so these are the kind of things that would come up in this. Requests for ongoing use of life support in a patient who is brain dead, with the caveat that this would be happening in a jurisdiction in which brain death is a recognized construct. That's the case in 49 of the 50 United States. At requests for euthanasia, right? There are legal prohibitions against euthanasia, and that's another circumstance in which we'd refuse. And then another example that is not a legal example, but a social policy example. If, for example, a surrogate or a patient were requesting for the doctor to forge records so they could jump the organ allocation queue, right, and someone in need of a transplantation, we say no to that based on a very clearly developed lung and other organ allocation strategy that is socially sanctioned and explicit. All right, so how should we manage conflicts about potentially inappropriate treatment? This is the second portion of the document. The first recommendation, this is the first portion of the document, consciously the first. The first recommendation is one about healthcare systems. Institutions should implement strategies to prevent intractable treatment conflicts, including, and we divided it up into two things, proactive communication and early involvement of expert consultants. So let me just take a minute and break down what we mean by this. The goal here is to recognize that in intensive care units, and more broadly speaking near the end of life, conflict should be expected, right? These are just incredibly difficult cases. And the idea that this will all happen and it will be rosy and easy is not a realistic expectation. The goal, though, is to manage conflicts in such a way that low-level conflicts don't become intractable. I think we've all had circumstances where what presumably should have been something that got worked out, something went wrong with communication, both parties dug in their heels, and what looked for all the world like something that could be resolved with just good collaborative decision-making became intractable. And so the recommendations in the policy statement have to do with making general recommendations about how to do this at the system level. So the kind of proactive communication strategies that we were talking about have to do with structured, scheduled family meetings, among other things, involvement of the interdisciplinary care teams, advanced communication skills training for providers. We were talking last night about Vital Talk and other approaches to really train clinicians in the moment-to-moment kinds of skills that are needed for these delicate conversations. And then finally, the third part of this recommendation has to do with creating a culture that fosters the expectation that expert consultants will be involved if just general good intensive communication is not leading to resolution of the conflict. And we were vague we were not vague, we were quite specific in the document, but about who is an expert in this. And the kind of expertise that is being referred to is around conflict resolution and mediation. In the document, we recognize that at different hospitals, there are different people who do that well. Social workers sometimes it's psychiatry, If there's a palliative care service, sometimes it's palliative care consultants. If there's an ethics consult service, sometimes it's an ethics consultant. Sometimes it's an individual clinician of some sort who is just very good in helping find collaborative solutions. And so the policy document recommended having this be part of the mental model for how institutions handle conflict, that when it is not yielding in productive ways early on, that clinicians consider early involvement of expert consultants. So I won't go into detail about the kind of systems level and clinician level skills that are recommended, but I'll direct you to another recent professional society guideline that lays this out more, actually lays out different kinds of skills to achieve shared decision making in ICUs, and this goes a great deal more into the kind of skills that we're talking about. And so why the emphasis? Why did we make recommendation 1 about prevention? That's not where most other policymaking efforts on this have focused. This is the reason. The gist of this slide is that with good communication, simple sort of doctors, nurses rolling up their elbows and staying at the table with families, the vast majority of conflicts get resolved. So there are 2 different studies that support this, one in an adult ICU and one in a series of pediatric ICUs, where they looked at the number of family meetings and the percent of cases in which there was a shared resolution to the case by the end of the sort of laid out amount of time. And so in magenta are the unresolved cases, and in the yellow are the resolved. And basically what you see is that after 3 or so family meetings, in the vast majority of cases, upwards of 99%, the conflicts are resolved, just with good communication. And so focusing on this, rather than the 1% of the intractable cases, seems to be a smarter place to focus our attention, to make sure that we as clinicians and health systems are doing the right kinds of things to make sure that resolvable conflicts don't become intractable. And then just a little bit of data that underpins the recommendation for expert consultation. This is a really interesting study that bridges empirical bioethics and health services research that was done by Larry Schneiderman, published in JAMA in 2003, in which they did a randomized trial of early ethics consultation in cases of what they described of value-related treatment conflicts. It was at 7 different ICUs. And essentially what they did is they randomized 551 patients in whom value-related conflicts arose to either an early ethics consult or usual care. And of course, in the usual care arm at these 7 hospitals, ethics consultation was available. It just wasn't given early. It was given as per protocol or as per norm in response to the clinical team requesting a consultation. And the main outcome measures that they chose in this study were looking at what they called non-beneficial treatment. Okay, I have problems with that label, but I think empirically what they looked at are among patients who died, and the overall mortality rate was about 60%. Did the intervention have any effect on hospital days, ICU days, or patient mortality? And what they found was a clear and significant signal across all 7 centers that early involvement of expert consultants in this study in the form of ethics consultants was associated with shorter length of stay amongst patients who died. Now, what's interesting, if you're paying attention on this slide, is that in the intervention arm, the mortality rate is 63% versus 58%. Not a statistically significant difference, but a slightly higher mortality rate in the intervention arm. I think one of the main critiques of this study is that there were no good measures to sort out whether these deaths are good patient-centered deaths or bad deaths, meaning deaths that were nudged along by the clinical team and don't reflect the patient's values and preferences. And
do you think that mortality was 57.8? Do you think that mortality that was determined death in ICU, or perhaps it's lower because they went on to a hospice?
So you would a perfect study that of course doesn't exist in the world would give us really detailed information about the proportion of cases in which life support was withheld, et cetera, and those data just were not reported. So we can't say. And that's the concern, is that was this good decisions being made by ethics consultants, or was it somewhat more coercive? I tend to, knowing the hospitals and knowing the individuals who were doing the ethics consultations, I do not think that's what was going on. But as empirical researchers, I think a degree of skepticism is always warranted to say, here's the shortcoming of this particular study. A couple other studies that have looked at this, less rigorously, but just to sort of, as we're talking about the notion of expert consultation and whether there's an effect on health service utilization, both for palliative care and for an individual patient advocate, patient supporter, there are similar data about shortening length of stay. Again, we have lots of holes in this evidence base, though. And just one last plug for thinking about prevention and intensive communication as a way to try to prevent latent conflict from becoming intractable. One of the veins of research that I'm most interested in is how strong emotions influence decision making. And over the last 2 decades, there's been a great deal of work with fMRI and other mechanisms to understand how emotions do influence decisions. And this is just a little schematic to help you think about this. So when we are, this is sort of the emotional arousalometer, when we're low, a relatively low emotional tone, and the emotions of relevance are anxiety and fear, typically when you ask people to do decision-making tasks and put them in an fMRI scanner, the parts of the brain that you see lighting up are almost all cortical, right? Almost all associated with a particular kind of what we call cool state decision-making, rational, deliberative, and we can appreciate trade-offs between competing goods, which is the essence of what the kind of decisions that arise in ICUs are. But think about, and sorry, it's not popping up here, imagine that the emotional arousalometer was up at 100%, and these are maximally stressed individuals who are being asked to make decisional tasks and put in an fMRI scanner. And there are experimental ways to achieve high emotional arousal. What they find when they image them is that the cortex shuts off, and what lights up is the amygdala, which is a very different kind of making decisions, right? So this is typically the decisions that are made. Just think about the kind of decisions that you make when you lose your temper or when you get a little crazy in a fight with your spouse, right? The decisions are not deliberative. You're not making great trade-offs. You're often doing things that you regret later. And we think of them as sort of the reptilian brain, a fight or flight approach to decision making that is usually pretty black and white and non-deliberative. So what I, as a clinician, conceptualize as part of my job and what we emphasized in this document is trying to move people from, generally speaking, a hot state to a cool state, which is not to say getting rid of emotions. That's not a realistic goal, but to say our job as clinicians is to help people have their emotions sufficiently in check, that they can both use emotion as a guide to what's important and also deliberate rationally. So my mental model, just for the clinicians in the audience, when I think about what's my job here, my job is to support the family in the ways needed for us collaboratively to make good decisions. And what does that look like? Well, I ask myself a series of questions. Have I moved them from a hot state to a cooler state? Have I given them the information they need to make good decisions? And have I helped them think about what decisions are most respectful of the patient as a person? And then finally, and I think really important, have I given them recommendations about what I think is most respectful of the patient as a person? And have I strongly advocated for that? And this is not a model of deference to, it's a sort of pure informed consent or a belief that autonomy requires no interaction. Right? I think this is a much more facilitated view of what is an autonomous decision, which is one that can have some give and take and conversation with someone else who holds some expertise. All right, so that's the first parts of the document, the recommendations about defining the nature of these disputes as generally value laden, but there are some rare cases in which they are strict physiologic futility. Thinking about how to prevent conflicts that are low level and could be resolved with good communication from becoming intractable. And then this final question of what do we do with the 1%? Right, the 1% of cases where the conflict does indeed become intractable. And I want to emphasize that it really is the 1%. Right? We should, although this is the stuff that people get most interested in and they sort of want to know the most about it, if you're really thinking as a pragmatist at the hospital level, you'll focus on everything else in the talk. And then this is just for the few hard cases. And we talked a bit about this morning and about with the fellows about the policies that exist here for this. Okay, so let me take you through 3 different options. In the face of intractable conflict, we could merely acquiesce and give patients and families all authority. We do whatever they say. We could go the other direction. We could say, well, we have all the authority and we get to decide. Or we could pursue a procedural dispute resolution strategy. And let me remind you to frame this out. These are cases in which what's being requested is neither physiologically futile nor legally proscribed. These are that cluster of cases in which the ends, the goals of the patient could be achieved, and there's just a legitimate disagreement between the clinical team and the family about what's permissible, so what fits within the boundaries of accepted medical practice. So the first approach, giving families all the authority, I think there are some very clear ethical problems with this that make it unsustainable. The first is that it confuses positive rights and negative rights. So remember, a positive right is a right to demand something of another. And these are far weaker than rights of what are called negative rights, which are rights to be left alone. And I think also this approach would ignore the ethical importance that has developed over time and is socially sanctioned of respecting professional integrity. It also may result in an unfair distribution of scarce resources. I think this one is a little harder to make because these cases are so rare that it would be a drop in the bucket, but I think it at least belongs on the list, the allocation of resources issue. The other part of this that I think is especially important from an interpersonal standpoint is that it may actually worsen the quality of dispute resolution in cases that are not intractable. And so what do I mean by this? Well, this is a piece that I wrote in JAMA in 2012 in which we raised the issue that if families have all the power, and I'll make the same parallel point with clinicians, it may fail to encourage the hard emotional and moral work that's sometimes needed to make decisions that are the right decision for the patient based on the patient's values, but are incredibly emotionally hard to make, right? I think those of us who are clinicians have many times encountered families who just, at some level, they cognitively know what the right decision is, but they can't do it emotionally. And if we allowed families to have all of the authority, the risk is that they would more reflexively go to the decisions that are easy rather than the decisions that are right. The second approach is let's just give individual physicians all the authority. And I purposefully say individual physicians. And what I'm talking about here is giving the one doctor at the bedside discretion to just decide and to enact his or her decision. So the first and I think the biggest ethical concern was illuminated in the data that I've already presented, which is that it risks subjecting patients to unwarranted variability and arbitrary decisions, because we know that clinicians, when faced with similar circumstances, often have divergent values of what's appropriate. Second, from a purely liberal democratic standpoint, little l liberal democratic standpoint, this approach really conflicts with our ideals about how to resolve conflicts about fundamental interests, right? Interests about how our lives are made, begun, or ended. We typically don't like one person deciding what happens to another person's body. And then finally, just as giving families all the authority may subtly disincentivize good decisions and good communication, I think clinicians, the same risk is there. You know, we value making collaborative decisions rather than imposing a decision on families. And I think it's hard, right? These are the things that keep us up at night. They're both the most gratifying parts of our practice, but they're also some of the hardest. And there may be a subtle disincentive for physicians to really engage in that work if they're given all authority to make these decisions over surrogates. And so Jay Katz, who was a wonderful psychiatrist at Yale, wrote in The Silent World of the Doctor and Patient a quote that I think really embodies the nature of this. The dilemma is that physicians and patients both bring their own vulnerabilities to the decision-making process. Both are authors and victims of their own individual conflicting motivations, interests, and expectations. And the reality of our lives is we have to find a way forward with imperfect people on both sides of this conversation. So the third option, and the option advocated in the ATS document, is resorting to what's called a fair process of dispute resolution. And let me just read the recommendation. You got this first part already. Potentially inappropriate should be used rather than futile. Next, clinicians should communicate and advocate for the treatment plan they believe is appropriate. This is emphasizing that clinicians should be engaged participants in decision making. And then finally, requests for potentially inappropriate treatment that remain intractable despite intensive communication and negotiation should be managed by a fair process of dispute resolution. So what do we mean by this? Well, just schematically, this is what we mean, and then I'll give the particulars in a moment. So clinicians make a claim, right? They say, I think that what's being requested of me is bad medicine. I think it's potentially inappropriate. They may have very strong feelings. They may say, I know it's inappropriate, or I really strongly believe. They may not even want to use the term inappropriate, but potentially. But the idea is that that initial claim, rather than being also the conclusion, is subjected to some sort of scrutiny, an external process of some sort that yields a determination that either what's being requested is permissible or what's being requested is inappropriate. And so let me just, before I show you the 7 steps recommended, let me just say a little bit about the ethical justification. This should sort of summarize what we've just talked about in the prior slides. The goal is to diminish the possibility that natural human limitations impact patients' well-being, to conform with democratic ideals for resolving conflicts, and these sorts of things are in the decision-making process. There's transparency, legitimacy, accountability, and I think importantly, the opportunity for appeal. Finally, third, to protect vulnerable patients by putting in place process protections that are similar to those available for patients in other contexts. What do I mean by this? Well, remember, when a patient sees an oncologist in the outpatient clinic and that oncologist says, I'm not going to administer the 4th line of chemotherapy, that patient typically has the ability to get up and ambulate to another clinician and seek out another opinion. In the ICU, our patients don't have that luxury, right? They don't have the ability to have multiple opinions on their care unless something is put in place to achieve that. And then finally, just as importantly, to give clinicians a sanctioned mechanism to challenge the decisions they believe are unwise. Just as families should have that option, clinicians too should not be compelled to do things that violate their deeply held beliefs. And so these are the 3 guiding considerations of the policy. Neither individual clinicians nor families should be given complete authority to make unilateral decisions, and that word is very important in this. Clinicians should not simply acquiesce to the requests they believe are harmful to the patient or violate professional integrity. And in response to intractable conflicts, the process of decision-making should satisfy basic aspects of procedural fairness. So these are the steps, and let me just walk you through them. I want to make sure we leave some time for questions. The first step, so what you have to imagine is that this is a case like the case I presented to you, and that the clinicians have done everything they think possible to achieve a negotiated agreement, including involving expert consultants. And the disagreement about, for example, ongoing life support remains intractable. So if in this circumstance the clinicians believe they should proceed with attempts to make decisions that override surrogates' requests, they should give notice that this process is being initiated to the surrogates. They should continue, the second recommendation is they should continue negotiation during the dispute resolution process. What we recommended was that there be a group, typically the ethics consultants or palliative care consultants or primary team, who remain in communication with the family while a separate body is considering the request. Rather than what I'm actually seeing in a case that I'm involved in right now, once this process was started, all communication stopped. No one talked to the family anymore, and it became a purely adversarial approach. Third, of course, this should have been done already, but just for checking of boxes, to make sure a second medical opinion has been obtained to verify the clinician's claims, or to at least verify that they're widely held. Fourth, to obtain review of the case by a hospital committee. Again, this sort of clunky language is meant to convey the hospital ethics committee, but was written more broadly because there are different hospitals that have different resolution mechanisms. If all of these steps are undertaken and there is consensus at the level of the hospital that what's being requested is inappropriate, the surrogates should be offered the opportunity to transfer the patient to an alternate institution. This with a nod of the hat to the idea that the values and virtues of individuals at one hospital do not necessarily map perfectly onto those at other hospitals. That's what underlies the request for transfer. Sixth, surrogates and this was an important and hotly contested one, surrogates need to at least be informed of their right to pursue extramural appeal. And again, the language is clunky but meant to be broadly generalizable. In the United States, this is to seek a judicial injunction. Right? This is no different. It's not giving them a new right. This right always exists. But what's important about this also is that this is not requiring physicians to go to court to seek permission. The onus of responsibility for that is on surrogates who are making requests that clinicians believe are outside the boundaries of good practice, and multiple steps of a process have confirmed that judgment. And then finally, at the end of this process, if all of these steps have been taken, either the surrogates pursued extramural appeal and the decision was against what they were requesting, or they didn't pursue it, then the clinicians should be allowed to implement the decision of the resolution process, which typically entails administering palliative measures and foregoing other measures deemed potentially inappropriate, or at this point inappropriate. So, empirical data, does this actually do anything? Is it feasible to do this? The closest analogy we have is a law that's been on the books in Texas since the late 90s called the Texas Advanced Directives Act. This is an approach to manage requests for what they called medically inappropriate treatment. I think capturing the same construct that we're talking about here. And let me just, for those of you who think, well, listen, we can never get rid of the word futility, it's just part of the medical lexicon, I'll just point out that this law has been in the books for more than 20 years in Texas. It does not contain the word futile anywhere in it. And when you talk to clinicians in Texas, they speak in terms of medically inappropriate. The term is essentially washed out of the literature there. So at Baylor, over 2 years after the law was passed, Bob Fine and others just studied how often they got consulted about these cases and what happened. They got 47 consults to the ethics committee over 2 years. And what I think is the most important point on this slide, and perhaps in the whole talk, is that these are cases in which the clinician said, there is no negotiated agreement to be found here. This is an intractable conflict. And in 37 of 47 cases, routine ethics consult involvement achieved a resolution, a negotiated resolution in which both parties agreed to the outcome. In 10 cases, there couldn't be. There was an intractable conflict. In fact, this proceeded to the more formal ethics committee review in an approach that closely but not entirely mirrors what the ATS document recommends. In 4 cases, the ethics committee disagreed with the clinicians that further non-comfort treatments were medically inappropriate, in essence telling the clinicians, no, you should provide these therapies. In 6 cases, the ethics committee agreed, and a 10-day letter was issued, which basically began the process of seeking out other hospitals in the area who might accept the patient and transfer. And in 3 of these cases, the families agreed to stop treatment before the 10 days elapsed. And in 3 cases, the patient died during the 10-day period. What's important, and you may be asking yourself, well, no one's ever seen this all the way through. Marty Smith recently published a series that looked across Texas and found that this policy over the last 10 years has been used on the order of hundreds of times and has actually been seen through to completion. The data are not perfect. There are lots of interesting questions that come up about to whom is it applied, how is it applied, are the steps reasonably followed? But I think these are the data that we have now. And so I'm going to skip this. We can come back to this if you want, but this just lays out some of the ways to proceed in the case of some slightly different clinical characteristics. And let me just end with the case resolution here. So this is the case I presented to you at the beginning. This was in fact a real case. I've practiced at numerous institutions, so I won't say which institution this was. But the process was followed according to roughly what's laid out in the ATS document. And in fact, the family said, we think this is appropriate. We don't know what's right, but we can't imagine stopping life support. The ethics committee was involved. Independent of the clinical team, they were involved in supporting the family. And then a hospital committee evaluated the case. The hospital committee came back and said, we think this is inappropriate. And the ethics committee informed the family of this. And the family, it had actually affected them. Not enough that they changed their mind, but they took it as a respectful sign that the hospital was taking seriously their considerations and putting it through what is ostensibly a fair process, a fair hearing. What changed for this family was when they were given the option to transfer the patient to another hospital. And the family actually took it upon themselves to seek out other providers. And every clinician they talked to, and I think the family sought out 8 different hospitals, and the clinicians involved sought out another 4, and every hospital said the same thing, which is we do not think this is good medicine. We think this is more harmful than helpful, and we're not willing to take this patient and transfer. And at the end of this, the family, quite without acrimony, said, we still don't agree with this, but we respect that you have respected us, and we respect this process. We are not going to push further on this. And the patient died very shortly after life support was withdrawn with comfort measures. So I don't mean to put a rosy picture on this. This was not an easy case, but I think when you think about the various ways that these kinds of cases could play out, this may be the least bad resolution in a situation in which really only bad resolutions are possible. So let me end here, and we have some time for questions. Thank you very much. Yes.
Both a question and a comment. First of all, this was excellent. I like the way you set us up by asking, is it futile or not? Because I agree with you that futility you can't assess until you first identify the goals. Something that I've used that also gets me to a high level of success. I saw you mention multiple times physiologic futility. But there's 2 other types, quantitative and qualitative. And what I do is tend to move down the list. For example, you could have a young woman, 28 years old, 2 small kids, metastatic melanoma in her brain. She's failed radiation, failed all treatment. She's comatose. Let's say she's in renal failure, and dialysis comes up. Is it physiologically futile? Well, it's going to improve her electrolytes, so it does fix the physiology work. So then I move down and say, quantitatively, is it going to improve the duration of life? And it might by days and weeks, and that maybe if the goal of the family is to allow her brother to fly in from Afghanistan to say goodbye to his sister, then again, it's not futile. They need those few days to get the brother. But if it's that they've said to you, the goal is that she's got small kids at home to raise, she needs to go home and raise kids, that's qualitative where you can then say, these therapies won't help. Won't help the qualitative. She's not going to go home and go to PTA meetings. And
May I say one thing before you go on? That's perfect. What I mean by that is, if as clinicians we could essentially show our math, right? What you just did is you showed your moral math. If you had said those things to the family and said, so it's not that this won't keep her heart beating. That's not the issue. And it may even not be the issue that we couldn't keep her alive for a few more days. What the real issue here is that, and then you lay out what is the future in terms of their quality of life. That's the kind of really good high-level communication that we are mostly advocating in this document, which is to bring people along rather than to go to adversarial processes, to really engage them deeply in sharing that kind of thinking. So I'm sorry,
Well, I was going to say, because I think that's perfect, because most of the time that works, and when it doesn't, it's oftentimes a coping mechanism where the family says, I just can't let go. And that's where that kind of Eric Rowland's compassionate paternalism kicks in, where you say, okay, I understand it, but I am strongly recommending that we not do this. A lot of times the family just needs permission. And what you described in your patient, your resolution, was in a way giving them permission to accept the judgment of many physicians and hospitals. So thank you very much. This was excellent.
Thank you.
One thing that sort of hovers in the background that a lot of people tend to overlook or don't talk about is the extreme discomfort that this situation involves for the patient. I mean, the bereavements must not be painless. the smell, the fact that they don't smell good, the fact that they lose control of their natural functions, their bowels and so forth, the embarrassment. I mean, there is a lot of pain and suffering that has to be factored in, I think, when you make the futility. It's not just survival.
Yeah, no, thank you. I couldn't agree more.
No other questions? Thank you very much.
Thank you.